Good afternoon. I'm Betsy McKay, and welcome to our panel on pandemic prevention presented by the studio at Harvard T.H. Chan School of Public Health. The COVID-19 pandemic revealed major flaws in global health. So today, we'll explore the tools and research now underway to track emerging threats of disease and stop them from spreading. From disease surveillance to wastewater monitoring and genomic sequencing, we'll learn how the world can prepare for the next pandemic and help prevent future outbreaks. So joining me today are Satchit Balsari, who is an assistant professor in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. Alexandria Boehm, professor of Civil and Environmental Engineering at Stanford University, and Mark Lipsitch, Director of the Center for Communicable Disease Dynamics and Professor of Epidemiology at the Harvard Chan School, and Director for Science at the Center for Forecasting and Outbreak Analytics, which is new at the Center for Disease Control and Prevention, and Sikulili Moyo, Laboratory Director at the Botswana Harvard AIDS Institute Partnership and Research Associate at the Harvard Chan School of Public Health. So our distinguished panelists will answer your questions, which you can add to the YouTube chat or by emailing studio@hsph.harvard.edu. Let's begin by taking a look back to 2020. It seems so long ago. COVID-19 quickly spread across the globe, closing international borders, shutting down restaurants and businesses, locking down neighborhoods. Despite this massive response all over the world, COVID continued to spread, overwhelming hospitals. Could each of you briefly share what you see as the biggest lesson from the initial response, those first few months, and what you think should have been done differently? Let's start with Mark.
Thank you, Betsy. I think what needed to be done faster and on a broader scale was to scale up our capacity to understand the geographic distribution and the scale of the problem itself. That has technological aspects, which we'll hear about today. That has administrative aspects of having industrial capacity ready to scale up for testing and so forth. And it also has epidemiological aspects of choosing case definitions such that you are more likely to detect cases early rather than miss them.
How about you, Ellie?
Yeah, that's a great question. And I think, just to build off of what Mark said, testing was really limited. And if we had had a wastewater monitoring network in place at the time, we could have easily flexed and started looking for SARS-CoV-2, RNA, and wastewater. And for wastewater, one test can capture 100,000 to 1 million people, whereas one test administered at a clinic captures one person. And if we had had that in place at the start of the pandemic, we could have gotten a sense quickly for the spread of the virus within the United States. But we didn't have that network in place, unfortunately, in 2020, but we do now.
Right. And Satchit, what would you say?
I'll take a little bit of a wider global South lens to this and say that the biggest problem, I thought, was the lack of imagination at all levels. We adopted physical distancing in a world that does not have the luxury of space. We talked about isolation in separate rooms when the vast majority of urban humanity does not live in an American suburb, not just folks in Hong Kong or Mumbai, but families in the Queens or in the Bronx. We talked about lockdowns that deprived millions of wage workers their livelihoods, plunging them into extreme food insecurity, not in weeks or months, but in days. School shutdowns, depriving millions of children their vital midday meals and providing no alternative means to reach them food. We had Zoom schools for households that barely had a phone, much less a smartphone, and households that had worked really hard for decades trying to put these children into school. In effect, as Professor Richard Cash and Vikram Patel wrote in The Lancet early on, is that a response to the pandemic really subverted global health. What needed to be done was that the response needed to be contextualized to the communities and the resources within which the response was being deployed. We needed more transparency. Communities, even key stakeholders like domain experts in epidemiology and public health, were completely blindsided by the very centralized decision-making where changes in testing and containment and movement policies were seldom explained to our populations. So going forward, I think trust, open data, and open science ought to be the non-negotiables of public health planning.
Yeah, really good points. And Sikulili, do you want to expand on that? I mean, you know, in the early months, some people thought that the pandemic, you know, the virus was sort of escaping Southern Africa, but as we know now, it's been there in full force.
Yeah, that's a good one, Betsy. We learned so fast that, you know, infectious diseases are a whole of society issue. And we quickly enough, we learned that the virus does not know any passport. And we needed to make sure that the whole global health is connected and we respond together. Responding in silos exposed the major societies in poor resource settings to ravage of the virus. So that was very, very important for us to realize going forward, we need to respond in tandem and work together. And of course, we saw that we raised the bar in vaccine production, but the inequalities that rose in terms of distribution of the vaccine also exposed weaknesses in our global health system. And I agree with my colleague about trust. We realize that trust is one of the most delicate but critical requirements for an effective pandemic response. And it's very important to work with the societies as we develop new tools and new vaccines so that we can work this together. Agility and speed are probably the new basis of differentiation. And we see that moving agile and making sure that we have a coherent policy in a global scale is very, very important. Global government policy matters, but we also realize that individual behavior was actually even more important, and we need to catch up in making sure that we understand individual behavior. Thank you.
We now know so much more than we did in 2020, right? So scientists are able to track the virus as it mutates, and we have more effective ways of detecting surges in case numbers. Satchit, you've been working on the COVID-19 Mobility Data Network, which tracks transmission using location information. So how is this information being used globally?
Thanks, Betsy. A little context to your question for those in our audience not familiar with the COVID-19 Mobility Data Network. You know, we started in March 2020 when all we had were non-pharmaceutical interventions, right? Like lockdowns and travel restrictions. The only way to know whether these were working was to measure the epidemiological impact. Did the R naught change? You know, were these restrictions and freedoms actually impacting transmission? We could not, however, just compare articulated policy to epidemiological outcomes. What we needed to do was to study the impact of actual population mobility on changing epidemiology. Are people still congregating? You know, are they moving about less? How have their commuting patterns changed? And if yes, how much change was good enough to actually have the desired epidemiological impact? We could, of course, do this through all kinds of surveillance, remote sensing, CCTVs, and whatnot. But what was universal, near ubiquitous, was location mobility data that's available from cell phones, either from cell phone towers or signals from social media apps. This builds on a decade of work, in fact, done at the Center for Communicable Disease Dynamics, led by Caroline Buckey and Mark Lipsitch. So in early 2020, we realized that the capacity to correctly interpret these data streams as they became increasingly available, technology companies started publishing these aggregated mobility data in, you know, a collective desperate attempt that we were all engaged in to respond to the pandemic. But one needed to understand the limits at both ends of the data pipelines. As Mark alluded to early on, the provenance of the epidemiological data as testing availability criteria changed continuously, as well as understanding the uncertainty, the bias, the representativeness of these novel data streams coming from mobile devices. That capacity was very limited, and policymakers did not have either the time or the ability to sift through complex analyses, even if done correctly. So in response, we launched the COVID-19 Mobility Data Network, which was essentially a voluntary partnership of over 70 research scientists, policymakers from around the world. We met weekly to advance the methods needed to correctly apply these emerging data streams to inform policy. But our research teams communicated daily with local, state, and national agencies to help them interpret these mobility data in the context of that particular unfolding public health policies in their jurisdictions. So for example, we found that mobility had decreased significantly in Manhattan, but not in the Bronx. And we're really lucky to work with a public health department that understood that the correct response to that was to provide more support to the Bronx so people could afford to stay at home and not send in a police force to enforce lockdowns, as was happening elsewhere in the world. In the past 2 years, these data and the analysis in our team, which is now called Crisis Ready. So the analysis from the Crisis Ready network has been used from California to Bangladesh, not only for the pandemic, but these data streams are now used for responding to forced displacement from wildfires in California or for receiving refugees from Ukraine. More on our work and our reports can be accessed on our website at crisisready.io.
So you've laid out really well how this type of data can help people, can bring more services to people and identify where the real problems are. But a lot of people are also concerned about privacy, and is someone tracking where I'm going on my cell phone, and I don't really want that. How do you address that?
Through full transparency. The regulation needed to protect the misuse of these data, by and large, does not exist, except for the GDPR in Europe, some data protection regulations in Europe, in California and elsewhere. So our team leaned heavily on using advances in data science, like differential privacy, to anonymize the data. In fact, a lot of technology companies that share these data selectively, almost only with academic researchers, do so by aggregating and anonymizing the data in-house before they share it with anyone outside. We're working with the OpenDP suite of tools. So this is statistical noise that can be introduced into data sets. It's an open source service that's developed in collaboration with Microsoft by Professor Salil Vadin at the Engineering School and Gary King's labs. It's to study how much noise one can introduce into these data sets without compromising individual or group privacy. Context, again, is really, really key. In recent months, we were dealing with a case in wildfires in California where the data were so aggregated by Meta that they had no public health utility for what we were trying to do. And so there was then a negotiation with the technology company to say, can you give us a slightly higher resolution of data? And they did, but that still did not compromise individual or group privacy. These are complex challenges that every society will have to negotiate. A year ago, we convened experts from academia, from industry, from law, and from policy to publish a consensus on how to strike this balance between the availability of data, the resolution at which it should be shared, the conditions under which they can be shared. And these will depend on, again, the trust relationships in society, all this while retaining utility. Our report is called The Use of Human Mobility Data for Public Health Emergencies. It's also available on our website.
Great, thanks, Satchit. It's such an interesting question because it gets right at one of the dilemmas or the conflicts that has arisen in the pandemic, right, of trust. So we'll come back to that. Let's look at another method of tracking COVID-19, and that's wastewater. Alexandria Boehm worked with cities in Northern California to monitor wastewater beginning in November 2020. Since then, that's grown into a national initiative called Wastewater Scan that tracks COVID-19 and other infectious diseases by sampling wastewater. So let's take a quick look at how she and her students developed these methods.
There's a huge pump at the bottom of the sewer that collects a lot of the sewage that's coming from the residential buildings. And then we'll pump some of that sewage up where an auto sampler samples every 15 minutes. And then we can take that composite and then take a liter of it and have the operators put it in an Imhoff cone where it'll just have time for the really big solids to settle down. That way we can decant and then take the liquid out.
Once we get the sample, we start to process it, and this is something that students and postdocs help with, myself included.
One thing that we think about is that the wastewater provides a really nice complement to the rapid test, because the rapid test you do at home, you get the information about yourself and you act accordingly. But that information doesn't get funneled necessarily to public health. Whereas the wastewater data is available to public health, it can inform pandemic response, it can inform hospital resourcing, it can inform variant emergence.
It's really fascinating. Ali, I think everybody's interested in wastewater, and it's, you know, the fact that it was a resource right there and that we're now able to use it. So can you talk more about how wastewater tracking can be used to anticipate new threats and warn public health leaders?
Sure. Well, I first want to say that, you know, people all over the world really mobilized at the beginning of the pandemic to start looking at using wastewater for monitoring COVID-19. And before the pandemic, before 2020, there was very little research on the use of wastewater for public health or infectious disease surveillance. But what's really amazing is that wastewater represents this amazing resource that seems to work well for surveying all sorts of infectious diseases, which I will come back to later, I think, in this forum. But first, just to say, wastewater is this composite biological sample. It contains feces, urine, sputum, mucus, scabs off the human body, skin cells, anything that goes down the drain, not just the toilet, but the shower or the sink. And so, you know, if you have the genomic sequence of the threat that you're interested in, whether it's an old threat or a new threat, you can apply an assay to wastewater to look for nucleic acids for that threat. So whether it's influenza A, which we know about a lot, or a new threat like COVID-19 or SARS-CoV-2, or an emerging virus that hasn't been around in a while like Mpox, you can apply that assay to wastewater and look for it. At first, you might not know for an emerging threat what the relationship is between wastewater concentrations and incident disease in the contributing population. But you do know that if you detect a nucleic acid, that somebody in the contributing population is shedding that material and is likely infected with that threat. So wastewater captures all the excretions from everybody in the sewer shed, and there can be as little as maybe 10,000 people served by a wastewater treatment plant, or there could be 2 million or 4 million, depending on the location. In the United States, 75% of the population is served by wastewater treatment plants, but in other places, far fewer people, if no one. In low and middle income countries, there may not be any centralized wastewater treatment plants. So this exact technology cannot be applied to all locations. So building on this theme of trust, one of the really important things about the use of wastewater surveillance to track new threats or old threats and inform public health, you can't just make the measurements and inform public health. I'm an engineer, and you can't just call up someone in public health and say, hey, I detected this in wastewater. You have to have a trusting relationship with public health so that they trust you and they understand this data stream and how this data stream can be used to inform their response to the pandemic and how it complements the sorts of data streams that they're used to seeing. And when we started this work, that trusting relationship was entirely absent. And it's not just a trusting relationship between me and public health, but this is a process that involves collaboration between wastewater treatment plants, laboratories, public health agencies, and researchers, and that network was not established. So in our project, we spend a lot of time with translation, teaching and learning from public health colleagues. What sort of information do they need? Teaching them about this environmental data stream, which is different from syndromic data or case data that they're used to seeing, with different sorts of variability, and setting up that really trusting relationship.
Thanks, and we'll come back to that too. Mark, at-home COVID tests are what we all use now. They're readily available. So many positive COVID tests are not being reported to public health departments. So given that, are the COVID case reports that many cities and states release still accurate? And what's the best indicator of an emerging surge in cases, given that data is now, in many different pockets?
Yeah, great question. The short answer is that a combination of data sources is more important than ever for the reason that you describe. So the report numbers are accurate in the sense that that is how many are being reported, but it's a changing and probably declining proportion of the total number of cases because most people aren't using reportable testing approaches. So the best way to understand the situation and the trends is to use a combination of case reports where the trend is probably meaningful, even if the exact number is not comparable to what it was, say, 6 months ago. To use innovative approaches to those test data, such as using the viral loads, which a team within our center at Harvard helped to develop a method showing that you could interpret trends in the direction of the epidemic from the distribution of viral loads among those who do get tested. Using wastewater as an early warning system is certainly important, and then being alerted to the possibility of a surge based on genomic surveillance and watching the trends in particular genomes, and finally sharing information internationally so that we can see what's happened, because in many times during this pandemic, other parts of the globe have been a little bit ahead of us in terms of having surges, and we can be more alert and watching the data more closely.
Great, let's talk about genomic sequencing now. The COVID-19 virus is mutating. We've seen it. We've seen lots of variants over the past 2.5 years. We're continuing to see lots of variants. So a key part of prevention is tracking those mutations. Sikhulili's lab discovered the Omicron variant at the Botswana Harvard AIDS Institute partnership. And the Omicron variant put the world on high alert, of course, led to travel bans. Sikhulili, can you tell us how that discovery influenced global public health decisions? And do you think those public health decisions were appropriate?
Thank you, Betsy. As Mark alerted, that the importance of doing genomic surveillance in public health has really showed us the value of intervening even when other parts of the world have not received the surges. We've seen that the Omicron variant, since we first sequenced it in mid-November in Botswana, has swept across the world and bringing a new wave of uncertainty about the future of the COVID-19 pandemic. And one of the things that we learned that was very important was the speed in terms of sharing the data and making sure that the world has time to prepare with the near real-time genomic surveillance that was critical in identifying the Omicron. And we see that the swift and transparent work of many scientists in Southern Africa provided the rest of the world at least some information that a potential surges are coming. And that was apparent because of the nature of the changes in the genetic makeup of the virus, with large number of mutations that we could characterize and see that some of these mutations really could drive a vaccine escape, could drive transmissibility. And that prediction happened to be correct. And that also led to interventions like renewed social distancing, and also we saw a sudden uptake in terms of vaccination programs, and governments were able to respond in a matter of days and not months. And that was very important to try and slow the transmission. One of the tragedies, of course, was the travel bans, which now when we look back, we think it was not the best way of dealing with the pandemic by closing out Southern Africa. In a matter of few days, the virus was already traveling in different places, if I have to use the word traveling, because the virus moves as the people move. So you see that doing travel bans really actually did more harms than really slowing the pandemic. That probably we need a better way of handling the pandemic. And we saw that the importance in terms of public health response is transparency. We need to share our data and collaborate with other scientists. And recently, as you know, the Omicron discovery was critical in the development of a new adapted Omicron adapted vaccine. So we see that this is important to monitor this variants, to warn as much as possible, but it's important that the response should be commensurate with the threat levels that the variants pose. Thank you.
Well, it's definitely great to have an updated vaccine. Just looking forward, Sikulili, just come back to you for a second. What are one or two things that you think should be done to better use genomic sequencing going forward to improve public health decisions?
I think COVID-19 has helped us to see the power of genomic sequencing, and the dream of precision public health is now possible because of the idea that we can compare sequences from multiple geographic regions, identify and track these variants, and see whether we see any possibilities of a threat or spots where the epidemic is moving. And it has provided opportunities to translate this data into actionable research, which is very, very critical. And additionally, we see that by rapidly identifying and seeing the viral evolution, it helps us to update our vaccines, which is very, very crucial as well. And one of the things we have also seen is the analytical tools that have been made available, the dashboards that further link genetic mutations and variants and changes in epidemiology, and the implications for clinical outcomes and effectiveness of vaccines. So we can evaluate the effectiveness of vaccines. And when the first sequence was shared from Wuhan, that was key for the development of so many diagnostic kits. So genomic sequencing is very, very critical. Even the therapeutics that were developed, you can link them to the idea that having that sequence really can allow you to analyze the possible phenotypic changes that can happen because of the changes in the virus. And so this is very important, that genomic sequencing can inform decisions about public health measures, can also alter clinical guidelines and vaccine and therapeutics, and also the diagnostics have really benefited from availability of sequences. Thank you.
So one of the other big innovations coming from the pandemic is the creation of a new CDC Center for Forecasting and Outbreak Analytics, which Mark is Director of Science for. So Mark, could you talk about how the CDC is combining its streams of data for prevention, so data modeling and analytics?
Sure. There's a long answer which I will spare you, but our new center is designed to do exactly that, and to pull in data from multiple sources and produce short-term forecasts, long-term scenario projections, and answers to analytical questions such as how should we formulate testing policy, how should we formulate isolation policy, is there any benefit to closing borders? And I agree with Dr. Moyo's evaluation, by the way, on the particular case. And we in fact did some such analyses with collaborators to help inform the lifting of the restrictions in the United States. To give an example that picks up on a lot of what's just been said, we were watching from CDC very closely as Southern Africa was experiencing Omicron, and it was clear throughout the world that a new wave of Omicron would sweep through due to exportation and then spread within countries. What was less clear in the early period was how severe those cases were going to be. And so in part to answer that question, and in part to see how quickly we could set up a rapid evaluation, we worked with Kaiser Permanente Southern California and a colleague at University of California, Berkeley, starting in the first week or two of December of last year, to estimate how severe Omicron cases were compared to Delta cases, because the question was, are these cases going to be as bad? And within with very, very rapid work by our colleagues, we were able to produce a preprint within about a month of the initial contact that Dr. Walensky, the CDC director, was able to publicly share, that indicated that there was a substantially lower severity per case, so that while it was a tremendously destructive wave, it was not as destructive as it would have been at a Delta level of severity, and that helped people to understand what kinds of planning was necessary. So we're really working within the Center for Forecasting and Outbreak Analytics to find more ways, particularly to combine high-quality clinical data with high-quality genomic data, which I think those two together are much more powerful than each of them individually.
Right, bringing everything together seems to be one of the biggest lesson.
Yeah.
So let's move a little bit beyond COVID-19 and talk about other threats like flu and recently monkeypox. So how are lessons learned from COVID being applied to broader prevention or prevention of other diseases, or addressing outbreaks? So Ali, you've been using wastewater tracking to detect monkeypox. Can you tell us about that?
Sure. So our hope with setting up this wastewater surveillance system for infectious disease from the start would be that it could be flexible and able to respond to both old and new threats that might come on the scene. And, you know, we already have this pipeline and collaboration in place where we have wastewater treatment plans, contributing samples, labs set up to run analyses, and then stakeholders who are interested in the results. So with the arrival of Mpox in the US for the first time in 20 years and sort of an outbreak situation with new characteristics, this was exactly the kind of situation that we wanted to be able to sort of flex our system to track. So we also, beyond the need to sort of understand how widespread Mpox might be in the US or in California specifically, we also wanted to confirm that we thought it would be shed into wastewater, which some early data came out from Spain confirming that the Mpox DNA was in a lot of different excretions, almost every single one tested from different infected individuals, and that we had a test to test for it. And luckily, CDC had some diagnostic tests that were already published that we tested and seemed to be specific and should work with this particular strain of Mpox, given we had the sequence available already from researchers, which is a plug for the need for genomic surveillance as well. And so monkeypox or Mpox checked all these different boxes. So we started applying the assay to our wastewater samples in mid-June. And luckily, we had built up that trusting relationship with public health so that even though we didn't know exactly what we were going to find or how it would relate to case data, they were still open and interested in seeing those results. And we started detecting Mpox DNA sporadically at our test sites and then much more often. And then the concentration started to increase over time. And what we found in the end, through close collaboration with our colleagues in public health, was that the concentrations in wastewater closely tracked incident cases in the sewer sheds where individuals were living, contributing to the wastewater, showing ultimately that not only can SARS-CoV-2 be tracked easily with wastewater, but so can Mpox. And so our public health colleagues remain very excited about the use of Mpox. And even though luckily, thankfully, cases have gone down quite a bit, and so have concentrations in wastewater, they have told us they do not want us to sunset our assay anytime soon because they're still concerned about concentrations increasing again and cases potentially increasing again. And they're really thankful and relying on this surveillance tool. We've also been working on influenza A and RSV and human metapneumovirus and have data showing that their concentrations in wastewater correlate well to usual case reporting that is available. And we know right now that RSV season is sort of upon us, at least in California and much of the US. We saw concentrations of RSV RNA rising in wastewater for over a month. So we knew that the RSV season was onsetting. And we are also seeing increases in influenza A in some states in the United States where influenza A cases are rising as well. So this just showcases that wastewater can be a really great tool for tracking all sorts of diseases. And in our case, almost every disease that we've looked at, we found that wastewater is a valuable tool for tracking it.
Thanks, and I'm glad I got my flu shot on Friday. Sikalili, where do you see the greatest need for outbreak prevention in Botswana and African countries? And maybe talk about how the World Bank's new financial intermediary fund might play a role in this.
Thank you, Betsy. The World Bank Financial Intermediary Fund is a great news for the rest of Africa. And you realize that most of the health systems were really caught unprepared, and most of the countries were not prepared. So one critical element is health system strengthening that requires really financing for pandemic preparedness and response, deliberate pandemic preparedness and response, establishing all the pillars of pandemic preparedness, I think is very, very important. And of course, I'm passionate about genomic surveillance. But having pathogen agnostic or multi-pathogen detection systems that are embedded in the emergency response and operations will be very, very important. I like the CDC Center for Forecasting and Outbreak Analytic Organization that Mark is leading. And I think it's going to be a lesson and a benchmark for Botswana and the rest of Africa that we can use outbreak analytics and feed information from different places to really try and analyze where pandemics may go and have pandemic intelligence resources that are really required in this part of the world. I think making sure that these financial mechanisms for pandemic preparedness and response these countries receive like a base amount for financing, sustain community-based health system capabilities is very important. We see the shortage of health care workers or essential health services being a target, at least to enhancement in this part of the world. And of course, we realize that addressing social determinants of health through making sure that all different levels of the society are prepared is very important. Making sure you invest in communication, invest in making sure that you break down the science, pandemic science, to allay any fears and reduce hesitancy becomes very, very important. I also see that the African region, we need to foster solidarity among the African countries and making sure that we align pandemic preparedness and response investments to make sure that we have a pool for commodities, for example, common goods, making sure that we have good standards for assessing our readiness, and of course, linking and making sure that we have international benchmarks that we attend to, including the pandemic treaty. That's very, very important. And also, I think expanding regional financing for pandemic preparedness is very, very important. We saw with the shortage of vaccines. So building capacity for manufacturing basic commodities that are required for pandemics will be very, very critical. Thank you, Betsy.
Yeah. Satchit and Ali, what challenges are you faced with going forward, do you think, as you get more data and we have new techniques for viral tracking? Is it primarily funding, policy, communication? What would you see as like your biggest one or two challenges?
There are possibly a couple, maybe some combination of those that you mentioned. The relationship between the state and its citizens is so strained right now. That lack of trust that all of us alluded to is precluding the partnership we need to both generate and act upon the data we have, right? Citizens are understandably unwilling to engage with the state or part with their data. The challenges with digital contact tracing apps, with vaccine uptakes, are particularly illuminative. The state has also been disingenuous in how it has handled data, including in some of the world's largest democracies, right? Whether this is data on incidence, data on mortality, state agencies have sometimes completely missed the mark. And the lack of these data then prevents us in the public health community from having access to the information we need to then help society to make informed decisions. And this then feeds into the lack of the right kind of expertise at the decision-making table. So you can have all the data and the analysis you generate, but governments around the world relied on consulting companies instead of domain experts to guide policy for a very long time in 2020. And I think the onus is therefore on us in the academy to reclaim that seat at the table. The way our group thinks through this is thinking about data readiness, methods readiness, and translational readiness, to say that there are challenges in accessing some of these novel data streams because they are with private enterprises. And that negotiation, just as Ali alluded to, has to be done in advance, right? You have to build your trust relationships with these technology companies, even if the data streams are not live. But you have to build this relationship. It takes an average of 1 to 2 years to have a data use agreement at any of our universities, right? So fix that problem before the disaster, begin to work on the analytic challenges, and then the translational piece where you have to be embedded with these public health agencies to take all these new methods and help the agencies act on it. Mark's Center is a fantastic example of what the world should be doing in terms of embedding these new skill sets into government response. Ali?
I think those are all excellent points and relate equally to wastewater, but I'll just add two things. The first is, just to reiterate that these relationships are really important, and having that trusting relationship and people embedded in public health who understand wastewater and wastewater data is going to be essential for making sure that this sort of technology can be used into the future. And then wastewater by nature is an aggregated data stream. There's no individual information available in wastewater yet, so it's not really covered by an IRB, an institutional review board. But there are still ethical issues associated with using wastewater for disease surveillance that have to be thought about carefully, just to make sure that the monitoring is occurring for public good, and that actions being taken that are informed by the wastewater are for the public good and not resulting in sort of anything negative for the communities that are receiving the wastewater treatment. And these things still need to be worked out, and the kinks haven't been worked out yet, because we have been operating in emergency mode for the last 2 years and are just sort of getting off that emergency mode at this moment. So I just think it's really important that when the next pandemic comes, we're all going to be worried and scared and panicking again, and also distrustful. If we have these trusting relationships in place, we're going to be in a way better position to use all the data and resources available to us to inform our response next time.
Mark, you're at the center of so much of this too. What do you see as the biggest challenges going forward?
Yeah, I think a real challenge but also an opportunity is the all of these novel data streams that we've been talking about are different from the ones that public health practitioners are used to using, and the crisis ready model of working through universities as intermediaries is one really great strategy for sort of bridging those gaps, but also we need to think in our training as a public health school how to ensure that people graduate not just from our doctoral programs, but from our MPH programs and other types of training with an appreciation for how different sorts of data, quantitative data, laboratory data, sequence data, wastewater, and others can be used and combined to produce a sort of big picture of what's going on. I'll say I'm very grateful for the nice things people have been saying. My greatest point of pride, one of my greatest points of pride now in our work at HSPH is that a number of our really first-rate graduates have chosen to join the Epidemic Intelligence Service program at CDC as their next step. And so training people for that career has been exciting, and I think we're trying our best to equip them with that kind of mix of skills.
The next generation. I want to turn now to some viewer questions. Anyone out there who has a question to ask, please put send it along. In the meantime, we have some that came in advance. One I wanted to address is the issue of public trust, which we have touched on throughout this discussion. So the question is, what kinds of communications surveillance projects could be undertaken to address the global threat posed by misinformation, disinformation, and the rejection of public health and governmental expertise and medical expertise? Mark, why don't I come back to you first, because you've been addressing some of this in your work with the CDC.
Yeah, I think trying to have a quantitative and systematic handle on what's going on in social media and other forums that affect people's behavior is an important activity. It's funny, I just got asked that question the last time I appeared publicly a few days ago. It's not something that we have formally been doing, but I think it's an important direction. I guess from within the Center for Forecasting and Outbreak Analytics, we've been trying to sort of take it from the other side. Dr. Walensky, the CDC director, stated recently the need for public health authorities to be more clear and more quick and more open about what we know and what we don't know, and to get data out even before it's absolutely conclusive. And so from the CFA perspective, we've been releasing what we're calling technical reports on monkeypox. We're working on our fourth, and we did we've done a few other such activities. The idea is to be on a fairly regular schedule and to be putting out not just a lot of facts and figures, which of course is very important, but also an assessment of what we think is the trend and the big picture, even though we know that predicting the future is an imperfect science. So we're clear about what we know, we're clear about what we think is going on, and we're clear about what we're not sure yet about, and what we're trying to do to understand that. And I think helping people understand the scientific process and the constant effort to narrow uncertainty will be one contribution to improving understanding.
Thanks, Mark. Another thing, I wanted to go back to genomic sequencing again for a second. One thing we haven't talked yet about much is what do you do with all the information that you get? So Sikulili, how much is too much, and how do you figure out, how dangerous a new virus or mutation really is? And every new variant we hear about of COVID-19 sounds alarming to the public. So how do you figure that out scientifically, and then how do you communicate to the public, and what do we need to know about all this going forward, either with COVID variants or now that there's so much genomic sequencing expertise out there, how do we do it with other viruses?
That's an important one. The fact that we see mutations in any virus does not necessarily translate to phenotypic changes. So it's very important that we communicate what the science says and communicate quickly. And even in areas sometimes when we are not certain what these changes mean for the virus. And for COVID, the virus being around for almost 2 years, there was so much that we didn't know. But with the use of data science and machine learning, people are now looking at these changes and modeling and being able with a good degree of precision to see if there are any more changes in the virus that might lead to more increased cases. So typically we look at these variants with these mutations where they are located in the virus, related to how the virus attaches to the human cell. And we make predictions either based on what we know before on the functions of those particular parts of the virus, or some studies that are done in the lab to see whether this is going to cause any new infections. So it's very important that even if we see some changes, that we do not cause too much alarm and acknowledge the uncertainty and generate the data very, very, very rapidly. I think we realize that it's important, especially to generate the data and share it rapidly and transparently, which is very important to inform public health response. We also learn science communication. People are worried when you say new variant. It's important to define whether it's a variant, is it of concern, is it something that at least being able to provide some judgment of what this kind of virus may give us is very important. I think we are better than where we were 2 years ago, 1.5 years ago. We are able to see that even the Omicron is changing. There are so many mutations that are coming into the Omicron. But the data science is already showing us that there is not a lot of room for the virus to evolve to a major jump in immune escape. And the background of vaccination and the background of the coverage and some of the treatments we have. Although we cannot be certain, but we have so much confidence that we think that the virus may not get a lot of room to suddenly jump like the jump that we saw in Omicron. But of course, although we say that, we must always treat that with the level of uncertainty that we know. So transparency, communication, agility in generating data, communication when you see a variant, number of cases increasing in different parts of the world. So global collaboration as well. Those signals are important in evaluating whether a mutation that we've seen in one part of the world is now causing new cases. So there's a lot to unpack in there, but we need to communicate fast, transparently, and also not cause unnecessary panic. And I say data science has become one of my love sciences because suddenly the genomics and the data scientists are converging, at least in terms of predicting what kind of evolutionary pathway a virus may take. Thank you.
So we have time for one more question before we're going to go to a lightning round. Maybe I'll turn this one to Satchit. Just what do you think is the readiness of the West right now, or the developed world, to share knowledge and resources to the developing world in controlling pandemics?
Pretty good. A lot of my colleagues here alluded to how quickly the sequences were available right from Wuhan to Omicron. I think very good. I think we have to really help federate capacity until there is regional capacity to do some of this work themselves. So it will not be sufficient to say we're publishing our data and publishing our science, but we may have to think very cleverly about how we can set up regional hubs where we can federate whatever local capacity we have. We have HSPH graduates being EIS fellows, but how do we take our entire ecosystem and see where folks are around the world to sustain a regional hub, a regional network that can respond to local emergencies? We've been trying to do this in Crisis Ready, but it goes back to your earlier question saying, how do you fund these enterprises, which are essentially loose trust networks?
So let's get some quick final thoughts from everyone. Imagine it's several years from now, or maybe not several years from now, maybe sooner than that, and there's a new emerging pandemic threat. In just a couple sentences, how fast could that threat be detected? Ali, let's start with you.
Well, assuming we have the genome of the threat, and let's just assume it's a virus, we can design and test and deploy an assay in wastewater within a week. And I think that week is only a week because of procurement of supplies from vendors. So I think in terms of having a flexible, nimble wastewater surveillance network in place, if that network is in place, then we can deploy and look for this threat very, very quickly.
Okay, Sukulili, what are your quick thoughts on this? How quickly could it be detected?
Given what we've seen with the rapid diagnosis of the Omicron by strategic sampling and surveillance, I think within a matter of days, if we continue random sampling and notifying any changes that we see in a population level and feeding information from epidemic intelligence, I think we can rapidly detect in a week and also move towards vaccine production in less than 100 days. We saw a remarkable 326 days from the first sequence to the registrable vaccine, breaking all records. I'm sure we can do it with diagnosis again.
Great. Mark?
I think it depends on how much investment we sustain. I like the optimism of the previous two answers, but they both had ifs, right? If we have wastewater and if we have random sampling. And I think the maintaining the momentum and the interest and not falling into the classic panic and then neglect cycle of public health funding is something we have to be conscious of. So with maintained investment, particularly in those two approaches, I fully agree. I'm just not 100% confident in that investment. And then the ongoing need to, once you detect it, track it and understand it. And those are distinct efforts that have to be scaled up as well.
Satchit?
I'm optimistic. I think we will narrow the window. The question is, will we start overshooting because there is then an overload of this data, right? We need to embed this into early warning systems like we have for other disasters, and then eventually learn to calibrate so that we don't cry wolf.
So we've got about 1 minute left. Let's try for one final question. Answer it in one word, please, or one phrase. What is the key to getting ahead of the next pandemic? Ali?
Ensure that we maintain wastewater monitoring across the US.
Okay, Sukulili?
Expand and maintain genomic surveillance in a systematic way, collaboratively, internationally.
Okay, Satchit, let's go to you and then Mark.
Readiness in peacetime. It is what we do between disasters that'll allow us to respond to the disaster.
And Mark, finally with you.
The combination and synthesis of all of those plus.
Everybody else said it, right? Well, thank you all so much. This has been a fantastic conversation. If anyone out there missed any of it, you can view the recording on demand on Harvard Chan School's YouTube page. So you're encouraged to do that. Otherwise, thank you very much for your time. We're glad to have spent the hour with you.